Evaluation of a liver mass. Jorge Marero, MD, MS, University of Michigan, and the Ann Arbor VA Medical Center. I have nothing to disclose for this presentation. When we have a liver mass, one of the important things that we have to do is a careful history, specifically the age, gender, history of cancer, steroid use, or different exposures such as vinyl chloride. We also need to do a physical exam in order to know if there's a palpable mass, fever, ascites, stigmata of chronic liver disease, or a bruit in the right upper quadrant. And then we need laboratory data that will help us determine if the patient has chronic liver disease, tumor markers, and so on. So that's the most important thing to do when we encounter a patient with a liver mass. It is important to remember the liver has a dual blood supply. 80% of the blood supply to the liver is through the portal vein, and about 20% is through the hepatic artery. When doing an imaging of the liver, you have to account for that and do a triple phase scan. Triple phase means a non-contrast phase, an arterial phase, and a portal venous phase. Tumors will develop their own blood supply, especially an arterial blood supply. So therefore, if it's not done in a triple phase manner, the CT or the MRI, tumors can be missed. This next slide shows what a triple phase imaging is. The left upper corner is an arterial phase done at 30 seconds, then a late arterial phase in the right upper corner, followed by a portal venous phase in the left lower corner, and a 5-minute delayed portal venous phase in the right lower corner. This is the type of scan that is needed to evaluate a liver mass. Unfortunately, most of the scans are only done in the portal venous phase, and therefore it limits the evaluation of a hepatic mass. This is an example of why a triple phase scan is critical. This shows an MRI of a patient with hepatocellular carcinoma. The image scan in the left upper corner shows a non-contrast phase. The one in the right upper corner shows an arterial phase showing an enhancing tumor shown by the arrow. In the left lower corner, it shows a portal venous phase in which no tumor is shown. And then the one in the right lower corner shows the delayed venous phase in which no obvious tumor is done. That's why triple phase is so important. There's a question of MRI versus CT, and MRI is superior to characterize lesions compared to CT. And it also does not require the intravenous contrast that is required by CT. So therefore, MRI is somewhat better than CT scan to evaluate liver lesions. MRI has been compared to CT to diagnose hepatocellular carcinoma in cirrhotic patients. The gold standard has been explant examination. This slide shows the number of patients, number of nodules, the number of patients with HCC, the sensitivity and specificity of CT, and the sensitivity and specificity of MRI. As these studies show, the sensitivity of MRI is better than CT scan, and therefore it is considered a modality of choice when evaluating and suspecting a patient with hepatocellular carcinoma. The first kind of benign tumor that we're going to discuss is hemangioma. Hemangiomas are benign and are highly vascular. Therefore, good triple phase evaluation is quite helpful. MRI is high signal on T1, and MRI is considered the gold standard. In the arterial phase, MRI enhances around the periphery of the lesion, but as it goes from the arterial phase to portal venous phase to delayed phase of the delayed portal venous phases, the lesion fills up with contrast. That is consistent with the centripetal filling of a hemangioma. Hemangioma has different types. Type 1 is an immediate complete hemangioma, but these are small, less than 1.5 centimeters. The type 2 is a peripheral nodular that fills completely. And the type 3 are the incomplete filling giant hemangiomas over 5 centimeters. The hemangiomas are benign and rarely need an intervention. The next tumor is a focal nodular hyperplasia. On MRI, they have hypo or isointensity. Their arterial phase shows a homogeneous blush, and that characteristic is called like a popcorn appearance. It does not have washout. And one of the important things with focal nodular hyperplasia is that it can develop a central scar in up to 50% of patients. The next slide shows a couple examples of focal nodular hyperplasia in which there is a central scar. The next slide also shows an example of a focal nodular hyperplasia, and you see the arterial blush, which is like a popcorn shape with a lesion in the middle, then that is called the central scar. Focal nodular hyperplasias are quite common. They are benign in nature, and no intervention is needed. The other type of benign lesion is a hepatic adenoma. They can be hyperintense in T1 as well as in T2. One of the important features of hepatic adenoma is they have fat. They can be arterially hypervascular, but really no washout on the delayed phase. Interestingly, some of these adenomas can have a thin capsule, and sometimes they can mimic hepatocellular carcinoma. The next slide shows an example of a non-contrast phase in which there's a thin capsule around it, but in the arterial phase, you see an enhancing lesion in the liver. This contrast between T1 and T2 is consistent with fat in the lesion and highly suggestive of hepatic adenoma. Hepatic adenomas are benign, and one of the main issues is that they can rupture. Most of these patients with hepatic adenomas, a resection is recommended or very close follow-up. Another potential complication of a hepatic adenoma is malignant transformation to hepatocellular carcinoma. And already there have been some molecular pathways that have been identified. So these patients with hepatic adenoma should be considered for resection or extremely close follow-up with MR imaging every 3 to 6 months. The next lesion that we're going to discuss is hepatocellular carcinoma. This picture shows an enhancing lesion in the liver, also with a central scar. But however, in the venous phase, there is washout. And also you see the central scar. So this is how we differentiate hepatocellular carcinoma from focal nodular hyperplasia or other benign tumors. This criteria of arterial enhancement and washout only applies with patients with cirrhosis. The next slide shows an example of a patient with washout. In the arterial phase, there is arterial enhancement, as shown by the arrows, and in the venous phase, there is washout of contrast or hypointensity, as shown in the arrows. This is highly sensitive and specific for hepatocellular carcinoma. So hepatocellular carcinoma, in the arterial phase, it appears hypervascular. Only very rarely does it appear hypovascular. And the delayed phase or the portovenous phase shows hypointensity, and that's one of the hallmarks. And sometimes there can be a thin capsule or a central scar. The next slide shows a fat-containing ACC in which on T1 there is isointensity or hypointensity consistent with a significant fat signal. That's a hallmark of ACC, that these tumors contain fat. Metastases from other tumors are quite common and probably the most common mass in the liver. In the arterial phase, most of the patients are heterogeneous enhancement. They are not extremely hypervascular, especially those over 2 centimeters in diameter. More often, they can appear hypovascular. In the portal venous phase, they might have irregular washout. The important hallmark of metastases when evaluated by CT or MRI is that these patients do not have cirrhosis. The next slide shows a hypervascular metastases, and these are enhancing in the arterial phase. We are not shown the portal venous phase, but there is no washout in the portal venous phase. So that's quite important. In the next slide, we see a hypovascular metastasis from colon cancer in the right posterior lobe. In the left, there you see the arterial enhancement, which is mostly in the periphery, and you see the same pattern in the portal venous phase. So there's no washout or no filling of contrast. The next slide compare patients with metastases and hemangioma. On the left-hand side, you see a patient with metastases in which the lesion enhances in the periphery, but there's no washout in the portal venous phase in the left lower corner. On the right, a patient with hemangioma shows also this peripheral enhancement similar to the metastasis. However, on the portal venous phase, there is filling of the contrast of the lesion. That is consistent with a hemangioma. To conclude, a triple phase examination is critical for the evaluation of someone with a hepatic mass. MRI tend to add more to the diagnosis and can characterize better lesions compared to CT scan. And each tumor has different characteristics that can be applied and can be differentiated.